Thank you very much. Of course, the topic is, actually, until I received it, about off-label drug use. I was not much aware what kind of a situation we were facing, me included. However, there are certain arrangements about off-label use of drugs when I looked at it from the ethical perspective. Before I started to prepare for this presentation, starting my lecture, I just want to share this information about it. It also involves some responsibilities, and we take a certain degree of burden. Off-label use is referred to the use of medication that was manufactured for a certain indication, for a different type of indication in a different way. And it involves many issues. From the patient's perspective, it is like a drug is tested on the patient using an unofficial drug, and the patient is exposed to a non-systemic and high-risk drug, and the patient may not be reimbursed by the Social Security Agency. Plus, they may become part of a treatment procedure that is devoid of the necessary standards. This was the patient's perspective, and the physicians are exposed to certain risks too. The physician will be practicing the profession without sufficient scientific foundation, and the speaker, who may be an authority here, and it may become a primary practice, and in this way, without any scientific foundation, you may have to use this drug. The outcome may not be predicted in this case, which also brings you under a great responsibility. And about this, if there's any kind of a problem, say, if the patient experiences a problem, even if it's not related to the drug, you may be faced with charges against you. In terms of general arrangement, there are certain issues as well, especially from looking outside. Again, there may not be a scientific basis for this practice, and about these practices, I think the pharmaceutical companies benefit from it a lot. If something like this happens, they create a new emerging market for their drugs. And without a significant investment, they are able to expand their shares in the market. And in the past, there were certain promotional bans on off-label use of drugs. In spite of the bans, the FDA has now created a new directive on the off-label use of drugs by the physicians. These promotional materials may not always reflect the truth, which may result in unjustified profit by the pharmaceutical companies. The regulatory authorities, of course, appears to be the Ministry of Health, and they do have some responsibilities on their own. In particular, they need to produce the directives that govern our practices. And for each field in medicine, there should be a clear framework on what can be prescribed and what may not. And if we are allowed to prescribe a drug, we need to take the responsibility. There is a directive of the Ministry of Health, Department of Drug and Pharmacology, on off-label drug use. Here, for the use of a medication, only drugs that are supported with scientific studies according to the indications specified on the package insert. And the treatment that's been done using certain drugs need to have a scientific basis, and they shouldn't be used in an off-label fashion without permission by the ministry. This is very clear. And then, can we write off-label drugs, prescribe off-label drugs? But there is no guidance on what's going to happen if you still do it. The only repercussions will be from the social security side. In terms of drug addictions, we have some offline drugs that may be used for alcoholism. The medications that can be prescribed include B vitamin complexes, 20% dextrose, paracetam, nootropic, and disulfiram may be used. And it may only be used from the oral route at a maximum dose of 500 milligrams. Symptomatic treatment of alcohol withdrawal may be treated with chlorozepate, diazepam, and oxyfencyclamin combination. For alcohol withdrawal syndrome, the first-line treatment is carbamazepine. And to treat the agitation as a result of alcohol withdrawal, I've never had a personal patient. However, hydroxyzine may be used for this indication. Maintenance of sobriety can be treated with asamprosate and naltrexone. Treatment of anxiety induced by alcohol treatment includes mesoridazine, thioridazine, which are neuroleptics, and they have central anticholinergic features, and we also have thieneptine. And treatment of depression that is seen during the treatment of alcohol treatment is thieneptine, and for alcoholic hallucinosis, asopramazine may be used. And drug use, except for alcohol, for nicotine withdrawal, we have nicotinell. For nicotine addiction, we have bupropion and varenicline tartrate. For the treatment of acute opioid toxicity, we may give naloxone, and for the treatment of opioid addiction, naltrexone may be prescribed. This, of course, does not reflect the reality about the treatment of addiction. If we are just limited to these options, our hands will be tied and there will be no way to treat our patients in a proper way. In the real life, we do use certain drugs, and if you look at the scientific data about these medications, it's a totally different perspective. A great majority of the drugs that we use are off-label drugs. And there are other mechanisms too which may lead us to off-label drug use. For example, for high-dose alcohol consumption, because the pharmacokinetics of a drug are modified, the effects may be very different. You may have to use it at very high doses in order to reach therapeutical levels, because the drug metabolism is inhibited or induced by the alcohol. In alcohol intoxication, the drugs that we generally use, the most frequently used one are the antipsychotics. And the antipsychotics include haloperidol, zopiclopentixol, and olanzapine. There are only a few studies on agitation as a result of alcohol intoxication. In case of alcohol withdrawal, most of the time our off-label drugs are alprazolam and lorazepam. And in cases with suspected liver pathologies, these drugs don't have much effect on liver, or they are not metabolized from the liver, or the liver metabolism is completed in a very short time. But both of the drugs do not have any indication for their use in case of alcohol withdrawal. For example, is a diazepam in an alcohol addict, because the withdrawal may be much more severe, we may have to use it at doses between 50 and 60 milligrams. The baseline alcohol consumption level is directly dependent on the drugs, and the upper limit that is dictated by the ministry, which is 30 milligrams, may not be suitable. We have to exceed that dose. For antipsychotics, again, in case of a withdrawal, maybe the excitation may be treated. Haloperidol may be used. Again, the other agents include suclopentixol, olanzapine, and amisulfuron. For among the anti-epileptics, we have carbamazepine. It's really interesting that it's indicated for this condition. There are many studies on carbamazepine for the treatment of alcohol withdrawal. There is a keying phenomenon with alcohol withdrawal. Each relapse of withdrawal episode is followed by a more severe one. And there are some theories on the effects of carbamazepine. Based on this hypothesis, carbamazepine was used very frequently for the treatment of alcohol withdrawal in the past. However, the use of carbamazepine, similar to benzodiazepine use, because it's not a real replacement therapy, other symptoms of alcohol withdrawal are not treated with the drugs. Usually it's not sufficient. In our own clinic, we use a dose optimization approach, and we also measure the plasma levels of carbamazepine. And we had a comparison with benzodiazepine and carbamazepine a couple of years ago, and very interestingly, in the benzodiazepine group, everything went very well. However, in the carbamazepine group, there were two epilepsy episodes, two epileptic seizures happened on two patients, and therefore we needed to reconsider the off-label use of carbamazepine for this condition. However, there are many studies around on the use of carbamazepine for alcohol withdrawal, and there are also certain studies with positive results on the use of sodium valproate and topiramate. The delirium induced by alcohol consumption, both during the withdrawal stage as well as during the other stages, because no drugs were available, all the drugs need to be used in an off-label fashion. There are many studies on the use of antipsychotics. Haloperidol and suclopentixol and olanzapine are only reported as case studies, and among the antiepileptics we have some case reports on the use of carbamazepine, sodium valproate, and gabapentin. Permanent disorders that are the result of alcohol consumption, such as dementia or amnestic syndrome. Here, fluoxamine and citalopram have been shown to be effective in some of the studies. However, these studies are usually small group studies, which mostly include like 20 patients. It's really hard to find cases, and they are really hard to monitor too. And there are 2 case reports on the use of antiepileptics for this condition. If you look at the type of alcohol consumption, in order to reduce the desire, or we may have avoidance therapies. To reduce the desire, antidepressants have been frequently used, and especially all of the SSRIs have been studied. And fluoxamine is one of the first drugs that have been studied. And first it was tried on animal model, and later on with fluoxetine many studies have been conducted. And we also had our own study. It was placebo trial. In the first 4 months it was shown to be effective, and later on the effect was disappeared. Antipsychotics are important too. Amisulfuron, risperidone, suclopentixol, and quetiapine are the ones that have been investigated. Among the thymoprophylactics, lithium, and in the past, lithium has been tried as a protective treatment. However, the lithium was only tried in a selected group of patients, and mostly it was the somatic way of alcohol consumption. This is periods of alcohol consumption followed by periods of sobriety. And these dipsomanic cases are usually individuals with a family history or history of previous episodes. Here you have a good effect from lithium, buspirone, acamprosate, lamotrigine, and topiramate. Many studies have investigated these drugs. Aversive medications, they just stop the intake of alcohol. The sulfiram is one of the drugs that they have a label indication. I think here we are taking it too far too. I sometimes use something like this sulfiram intoxication. It is beneficial for some cases. There are these long, slow release forms. They may be used in the subcutaneous, and there are the depot slow release preparations. It's injected into the muscle, and for 40 days you have a constant release of the sulfiram into the body. And of course the coexisting pathology may also be important in terms of comorbidity, especially if you have psychosis. The effectiveness of some medications may change. If psychosis is the comorbidity in addition to the alcoholism, for example, for flufenazine, dicaonate has better results compared to haloperidol, both for alcohol consumption as well as for psychosis. If you look at atypical antipsychotics, clozapine compared to the classical antipsychotics, it has dual effect. It reduces the consumption and the amount that is used. And the outcome is better compared to the others. The final sentences, please. Although drug abuse does not have an effect on the treatment response, olazapine had been found to have less response. If you look at off-label drug use, this happens very frequently in our own practice. In the cases who present to us, if you look at the off-label drug use for alcohol addicts, 40% of the drugs are prescribed off-label. But this is because alcohol treatment is very well defined. If you have a complicated alcohol withdrawal, and it may also further increase when there are other problems as well. Especially when you talk about illegal drug abuse, here the only option are the off-label drugs. As I said in the beginning, we are exposed to the risks that I've described in the beginning. The Turkish Society of Turkish Psychiatrists have established a group to review the indications, package indications of the different drugs for the treatment of addiction, for antidepressants and antipsychotics and mood stabilizers. There are now package insert indications, and according to the society, only antidepressants are recommended for the treatment of drug abuse. However, this of course limits our options. I believe this may be a way, an instrument to our ends. Maybe we should reconsider our use of these drugs in our own centers as well as on the society level, and then maybe we may file a report to the Ministry of Health. Because in terms of law and in terms of malpractice, this will avoid any problem.